actually, I'm really happy to see that we are hosting that intensive care chapter case scenario based. And as you all know that we have one of the best intensive care team in North Malabar. Actually. Dr. Jaykrishnan and his team is doing a really wonderful job and also teaching our postgraduate students and treating very rare and interesting cases. And he's an apt person, actually. All the young postgraduate students, actually. And one interesting thing I have noted is that most of the postgraduate students are very, very, very eager to go for the PIC post, even though it's very hectic. And even our SRs also, they compete to go for the PIC postings. So I wish all the best for this program. And I really thank IAP Peritoneal for taking up this along with the Intensive Chapter as well as our Department of Pediatrics. And I hope that future we'll be planning further such events so that we'll have more interesting cases, more problems or problem-oriented classes in the Intensive Chapter. So thank you, ma'am. Thank you all. Thank you.
Thank you, sir. Next, I would like to invite Dr. Mohandas Nair, President IAP Calicut, to say a few words.
Sir,
okay, then then I would like to invite Ajay to say a few words in the absence of Mohandas, sir.
Thank you, Dr. Debo. So IAP Kozhikode actually is proud to host one of the clinical meeting of IAP Kerala Intensive Care Chapter. I think our IAP Kerala Intensive Care Chapter is one of the leading subspecialties now, with a lot of activities happening in emergency care, a lot of planning by Shija ma'am and Dr. Debu. So and I wish the team IMCH all the success for today's program. Thank you.
Thank you, Dr. Ajay. Next, we will straight away go to the session. The moderator is Dr. Jaykrishnan, who needs no introduction. He is additional professor of pediatrics and in charge of PICU, Calicut Medical College. He has got a lot of presentations and publications, and he will be moderating the session, which includes case scenario discussions. And over to Jaykrishnan, sir, for introduction of other faculty members and presenters. Jaykrishnan, sir.
Okay. Good evening, friends. My thanks to the Intensive Care Chapter team for this opportunity in the first place, Dr. Shrija and Deepu, and also Ajay and our beloved HOD, Dr. Ajit Kumar, for this opportunity, and Dr. Vijay Kumar. So what we plan to do today is to present 4 interesting case scenarios here. In fact, it's a mixture of different types of cases, not related to one another in any way. Only thing is that as pediatricians who take care of critically ill children, there is some kind of a similarity between them. And to discuss the cases today, we have our own faculty, Dr. Fiji, Dr. Shamim, and Dr. Sadiq, who are actually part of our PICU team, and who have, in fact, many years of extensive experience in taking care of critically ill children in our PICU. And the cases will be presented by our residents, junior residents. We have 4 cases. The first case will be presented by Dr. Deepa Francis. Then second case by Dr. Yasmin Latif. Third by Dr. Pooja. And the last one by Dr. Rose. Now, I invite Dr. Deepa Francis to present the first case.
Thank you, sir. Good evening, all. So today, I'm here to present an interesting case we had in a PICU last month.
Oh, sorry. So I have to share the screen. 1 second.
Can you get this?
One second.
So is the screen visible?
It's not visible. Let me see. 1 second.
It's not visible.
Is it visible now?
Yes, sir.
Okay. I'll make it the play mode. Deepa, can you see this?
Okay. Yes, sir. Good evening, all. So today I'm here to present an unusual case of liver failure in an infant we had in a PICU last month. But I can't.
Oh, sorry. Sorry, I have to do that. I forgot. Sorry
I
for
can't
that.
space this.
Okay, just tell me when you want to move the screen.
Okay, okay.
Yeah.
So now the screen is not visible for me.
It's not visible?
It's visible.
It's visible, sir. It's visible.
I saw it. Okay. Presenting the case of a 1-year-old girl who was unimmunized and developmentally normal. She presented with complaints of fever and cough for 1 week, breathing difficulty for 1 week, and yellowish discoloration of eyes with increasing sleepiness for 4 days. On presentation to PICU, the child was drowsy, had respiratory distress. Next slide. With palpable hepatomegaly and jaundice. So the child was a well-nourished child with nil significant past history. On examination, we had tachypnea and increased work of breathing. There was clinical jaundice and hepatomegaly. The child was drowsy with mild hypotonia and easily elicitable reflexes. The possibilities, given the working diagnosis of pneumonia with possible liver failure, the possibilities we considered were probably hepatitis of viral etiology, drug or toxin-induced liver injury, or immune-mediated liver injury. Coming to the investigations revealed an elevated CRP, an elevated liver enzymes, the PT-INR, which remained elevated even after vitamin K, and EEG also showed a diffuse slowing of waves. The child was started on ceftriaxone, vancomycin, and oseltamivir initially. The liver failure was managed with supportive measures with vitamin K and N-acetylcysteine. The fever spikes reduced, jaundice improved, and the sensorium improved. On further investigations revealed an elevated level of serum ammonia. The viral markers for hepatotropic viruses were negative, and the adenoviral RT-PCR was positive. On day 5 of hospitalization, the child developed new onset fever spikes with worsening distress. On examination, we found the liver was palpable 3 centimeters below the costal margin, and air entry was reduced on the right side. The X-ray showed right-sided pleural effusion. The USG thorax was suggestive of empyema. Antibiotics were hiked to piptaz and vancomycin. ICD was inserted. It drained clear fluid. The blood culture and pleural fluid cultures were sterile. ICD was removed after 5 days. The child improved eventually. Respiratory distress subsided. Sensorium improved, and there was no jaundice clinically. LFT was also improving.
Now I will invite Dr. Shamim to give comments regarding the case. Dr. Shamim? Shamim, are you there?
Sir, I was not able to unmute. Now I am able to unmute. Okay. So next slide. Good evening, everybody. In the later half of the 2021, there were reports of an increase in the severe acute hepatitis cases of unknown etiology in the children from various parts of the world. Next slide. Next slide. In the November 2021, from the Children's Hospital, Alabama, they noticed the unusual clustering of liver injury cases, and of which 3 were acute liver failure cases. And all the children were less than 5, and they were previously healthy, and all of them were COVID-19 negative, but they were positive for the adenoviral infection. And there were similar cases were reported in the next few weeks. Similar cases also reported from the various European countries, from many cases from the United Kingdom. Next slide. By May 12, 2022, around 450 cases of similar illness were reported worldwide, with 11 deaths, and almost nearly 31 were waiting for the liver transplantation. The most of all, universally, all of them were negative for the common hepatotopic virus, that is A2E, and they presented with jaundice in 73% of the cases, and followed by the vomiting, diarrhea, and pale stools and fever. And the respiratory symptoms are present in the 19% of the cases. And from the data from the UK Health Security Agency, 126 out of 91 of the 126 children were positive for the adenoviral infection. And many of them were subtyped as adenovirus type 21. And 18% of the cases from the UKHSA, they also showed the SARS-CoV-2 positive. And the first alert from the UK came in the April 2022. Next slide. And following that, the WHO came with the case definition of severe acute hepatitis of unknown etiology as a person presenting with an acute hepatitis with common hepatotropic viral markers negative, with an AST and ALT more than 500, and whose age is less than 16 years or younger since 1st October 2021. An epidemiologically linked person as a presenting with an acute hepatitis of in any age, who is a close contact of probable case since 1st October 2021. Next slide. And the data from the UK, that's European Center for the Disease Prevention and Control, demographically, these children, most of the children are under 5 years. The three-fourths of all the children are less than 5 years. And from the US data, the median age was 2 years. And there is a slight female predisposition from both UK and also from the US data. Next slide. And the viral detection was maximum from the whole blood PCR compared to the other sample. Next slide. So the etiology and pathogenic mechanism for this still under investigation. The adenoviral infection does not explain the severity of this clinical picture. So the proposed hypothesis include increased susceptibility to a lower level of circulating adenoviral infection during the COVID pandemic, or a potential emergence of a novel adenoviral infection, or a SARS-CoV-2 co-infection. So adenoviral infection actually is a non-enveloped DNA virus. It causes respiratory, GIT, urinary, and also the conjunctival infection in the pediatric age group. Actually, the respiratory infection is the most common illness that we commonly encounter, and the subtype 1 to 7 is most commonly associated with the pediatric respiratory infection. The adenovirus type 21, that is actually usually associated with the diarrhea, vomiting, fever, along with the respiratory symptom. And is very unknown. It is not known to cause a hepatitis in otherwise healthy children. But there were reports of severe hepatitis in the immunocompromised children with the adenoviral infection. Next slide. So the treatment is mainly supportive, with covering the antibiotic to treat the secondary infection. Next slide. The prevention is mainly hand hygiene, respiratory hygiene, personal protective equipment, and environmental hygiene include the regular cleaning of the commonly touched areas and the surfaces with the sodium hypochlorite solution, and the non-metallic object with the 70% of the alcohol, and also preventing the overcrowding, and adequate ventilation. Next slide. So this is the data from our PICU from the 1st January to the May 15 from the PICU from the last 5 months. So we have total 20 positive cases for the last 5 months, and the male to female ratio was 12 to 8 with a mortality of 2. And now the age group is most commonly affected was less than 1 to 5 years. So most of the children, out of these 20 cases, almost 16 cases were 1 to 5 years. The common presentation of adenoviral infection that we were now PICU was bronchopneumonia. That was present in 12 cases, including 1 empyema and the hydropneumothorax, followed by the episodic base upper respiratory tract infection with atypical febrile seizures, hepatic failure, acute encephalitis syndrome, ADD with shock. So we have one child, actually this child was not admitted in the PICU. He presented with a bone marrow failure with the hepatitis. And this child actually, he has also previous infection of hepatitis A, followed by the patient developed this persistent jaundice. And again, the patient positive for the nasopharyngeal adenoviral PCR. And the patient have a persistent bone marrow failure. Now the patient is waiting for the bone marrow transplant. And the child with an AES, he presented with hypotonia and hypotonia. His nasopharyngeal swab was positive for the adenoviral infection, but his CSF viral panel, including the adenoviral PCR, was negative. His MRI and EEG was normal, and he's still under follow-up. He's not recovered till now, completely now, and he later developed some abnormal movements. And he actually tried with an his autoimmune panel was also negative. He was not improved now. He's having some abnormal movement, and now he's started on oral. He was pulsed with the methylprednisolone, and he's now on oral steroids. Still, he's not actually he's under follow-up, still having abnormal movement, and his sensorium is not completely become normal now. So the comorbidity increases the mortality. That is from the data from our data. Actually, we have the 5 patients with a comorbidity, and out of that 2 patients died. The children who died were one with BALL, who developed a bronchopneumonia, the adenoviral bronchopneumonia. That was one child. The second child was a child with a global development delay with genetically proven Patara syndrome, who developed with an adenoviral infection. That child also expired. All the other children recovered almost near normal, except that AES child. So the adenoviral infection may be a potential cause of acute severe hepatitis, particularly in this season. The children with comorbidity and immunosuppression have a risk of severe infection and mortality. The treatment is mainly supportive. Thank you.
Thank you, Dr. Shami, for giving us a clear overview of the current global scenario of adenovirus infections. And we don't know whether this actually is part of the global outbreak that's going on now. And in fact, 2 years back, just before COVID started, we had a large outbreak in our ICU. A lot of children were admitted with adenovirus, all complications, including meningoencephalitis, myocarditis, pneumonitis, hepatitis, hemophagocytosis, all complications were there, and very high mortality also at that time, just before COVID. And somehow we could control the outbreak. It is highly infectious also among the patients who got admitted in the hospital. Hospital-acquired infections were also there. And maybe thanks to COVID, that subsided by good January, February 2020. I think we'll have a discussion on this now at this stage and move on to the next case after that. That'll be better, I think. I would like maybe some of the attendants. Ajay, is there anything in the chat box now?
No, sir.
Jayakishan, can I
you can unmute the question?
Jayakishan, can I ask? Any global pandemic, any variant, any different variant of adenovirus so that they have reported, or
Yes.
is it the same, like any?
So they have identified the adenovirus type 41, subtype 41.
We are trying
Yeah,
to
whether
get
we had
whether
done
to
the
run.
same, whether it is 41 here.
Sir, we are trying to subtype our
Yes.
adenoviral infection from our micro. Actually, we are we told the microbiology people actually they're trying to subtype our adenoviral.
The 2019 outbreak was serotype 7, which is known to cause large outbreaks in PICU settings, ICU settings, and cause a lot of complications. I hope, but then this looks like this presentation is different. Clinical presentation is different from what we had in 2019. So unlikely that this is serotype 7 this time.
So role of any antivirals?
The antiviral drugs are actually the antiviral drugs, that is cidofovir. It's recommended only for the immunocompromised children. There is no report. So even for this severe acute hepatitis, that is from the Alabama. Actually, they have they having nobody has tried the cidofovir, the antiviral drug for an immunocompetent. There is no case reports are there for an immunocompetent children with an adenoviral infection.
And any viral load
Viral
we have done?
No, we haven't done the viral load. We haven't done the viral. The children, the child with that BALL, actually we are given the IVIG. That is because in many case reports they have tried the IVIG.
Do we have cases encountered in other hospitals also in Kozhikode? Ajay?
Not with we didn't send for any viral studies, sir. Adenovirus we couldn't get.
Okay. Shall we move on to the next case then? Okay, the next case will be presented by Dr. Yasmin Latif, who is our postgraduate student. Yasmin?
Yes, sir.
Yeah. 1 second. This is not moving now. Let me see. Yeah.
It's moving now, sir.
Yes.
Yes, good evening, all. Good evening, all. So I'm going to talk about the changing epidemiology of Shigella cases, whether it is a new threat. This is the first case, which is the case. It was a 10-year-old boy who presented with high-grade fever, watery loose stools, and vomiting for 1 day. And they also gave a history of altered sensorium since that day morning, but there was no seizures or any other complaints. And there were similar complaints in the mother and sibling. They both had loose stools. And when the child presented to our PICU, the child was encephalopathic. And also he had features of compensated shock, and his cardiac examination revealed muffled heart sounds. There were no other focal neurological deficit. His investigations showed a total count of 5,000. Absolute leukocyte count was 800. The platelet count was normal and CRP was highly elevated. The blood gases done at admission showed metabolic acidosis, and the ECG had some abnormality, and the stool Shigella PCR sent was positive. So this is the ECG done on day 1, which shows an abnormal T-wave axis and inverted T-wave. As this circled areas in V6, there is inverted T-waves. This was the ECG done on day 1. And on the next day, we did a serial ECG, which showed junctional rhythm and T-wave abnormalities. And later serial ECGs were done, and these abnormalities were reverted, and his ECGs got normal. and he was treated with IV fluid bolus. But with the first bolus, he developed features of fluid overload, and hence early inotropes were started. And he improved on inotropes. And also because he was encephalopathic, 3% saline infusion was started, and ceftriaxone antibiotic was also started. He improved, his shock improved within 24 hours, and his encephalopathy also improved. And we discharged the patient after 5 days of his after completing his antibiotics. So this is the next case, which was a 3.5-year-old boy who presented with high-grade fever and 3 episodes of seizures in the past 12 hours. And he presented to us in post-ictal state. And initially, we started him on 3% saline infusion in view of prolonged post-ictal state. And later, during the PICU observation, he developed 2 episodes of loose stools. And his investigations showed a total count of 2,300, an absolute leukocyte count of 900, a platelet count. The platelet count was normal, and CRP was also elevated. And an ECG done at admission at his heights of fever showed global T-wave inversion. And the repeat ECG done the next day was absolutely normal, and tropi was negative, and there were no features of shock in this patient. And we treated the patient with antibiotics and IV antiepileptics. And this is the ECG, which showed global T-wave inversion. The circled areas shows T-wave inversion in the lateral chest leads. And this is yet another case, which was a 5-year-old girl who had history of fever for 2 days with vomiting and loose stools, 5 episodes. There was no history of any blood in stools. There was clustering of cases in her locality, and they also gave a history of irrelevant talk, not only during heights of fever, but during the past 2 days. And at presentation, she was in compensated shock, and she also was managed with fluid bolus, and we had to start her on inotropes because of fluid refractory shock. And her ECG at admission also showed prolonged QT interval and global T-wave inversion, and ABG showed metabolic acidosis. So Shigella infection is an acute invasive enteric infection which clinically manifests as diarrhea, which is often in textbooks it is described as bloody, but blood in stools is not a feature in most of the cases. Initial days they can present with watery stools, which can later turn on to be bloody, and their high-grade fever may also be a feature in these cases. And neurological symptoms are among the most common extraintestinal manifestations in cases of Shigella, and they can present with seizures, altered sensorium, confusion, and these were the predominant neurological symptoms in our cases as well. And we have also seen that shock in Shigella is not always fluid responsive, and there is an early myocardial involvement seen as these ECG changes, and this early myocardial involvement is not uncommon in these cases.
Thank you, Yasmin, for that clear description of our cases. In fact, life-threatening illness related to Shigella continue to get admitted throughout the year. But then this is the time, that is May, June, is the time when we get the maximum number of cases. Almost half the cases in a year we get during this monsoon season. It's end of summer and then beginning of the rainy season. So this is our data during the last 6.5 years when we actually started collecting our data in 2016, when we started actually having deaths related to Shigella infection. Till that time, we never had mortality related to Shigella, but then the first case we had was in 2016 when one child was brought in a moribund state and then died within a few hours of admission with severe encephalopathy. So this data actually includes only culture and PCR positive cases, but then there are other cases where we have a clinical diagnosis of Shigella encephalopathy, many other cases, but then 106 cases in the last 6.5 years. And it's extremely difficult to culture Shigella in stool. It's an extremely, it's very difficult to get this culture positive unless you plate the sample immediately after collection. So we got it in 40% of the cases, and almost, except for 1 or 2, all cases for Shigella Sony infection. And the main reason why these children were admitted for was encephalopathy, almost 92% of them. And this, the next point is the most important thing, I think, now that we have started recognizing that many of these children have myocardial involvement also, which is not reported, I mean, extremely uncommonly reported, like only just 2 or 3 cases reported worldwide, this cardiac involvement in shigellosis. But all those sick cases who get admitted in the ICU and who have shock, almost 45% of them are fluid intolerant. So they need to be started on inotropes. This is one point that all of us pediatricians need to remember, that in shigellosis, it's not just fluid loss that is causing shock, but possibly myocardial involvement also. And we had almost 17% deaths out of this 106, 18 died. Okay, the reason why I think we thought of presenting this again now is because of this season, we continue to get cases again. The case in Kasaragod district last month, the child actually most likely had the severe toxic encephalopathy due to shigellosis, AKD syndrome. The child was, in fact, I think, taken to the hospital dead. So all of us need to be aware of this. Thank you. Ajay, do you have any questions?
Somebody has asked whether these cases are Shigella positive, the presented cases.
Yes, all these cases were Shigella positive. PCR was positive. Is there any other question? You can't see the chat box from here. Okay, let me see. Stool culture positivity, we got it only in 6 or 7 cases during this season, positive, because for the reasons that I already mentioned. But then we got PCR positive in all cases. Encephalitis or encephalopathy, it's actually encephalopathy. Most of the cases have CSF, normal CSF, when you do a CSF analysis. But then if you do an imaging, they all have severe cerebral edema that is causing this. The exact reason why these children get encephalopathy is not clearly understood. Most likely, this is related to some kind of toxin that is generated, but then that's not proven. PCR was done in stools. Rectal swab. We have not noticed HUS due to Shigella so far. It actually, the extraintestinal manifestations that we have noticed is mainly the brain, most of them, and the heart. And most of them have very high fever to begin with. And we had 2 children who had Brugada pattern seen in the ECG during the peak of fever. In fact, the Brugada syndrome actually presents during the height of fever with ventricular arrhythmias and all that. But we had 2 cases. The child was having very high fever. We took an ECG, and that is showing, or I have not shown that here in this presentation. And then once the fever subsided, the Brugada pattern also subsided. So I think this somehow affects the heart also. That's also important to recognize that. I'm not sure whether vitamin A is effective or not. We don't use it regularly. I don't know how much this PCR test costs, because we get it done free of cost in our hospital. I'm not very sure about that. Do you do this, Ajay, in BMH? Ajay is not there. Antibiotics increasing, and we have not encountered that. In fact, I think what we have seen is that early initiation of antibiotics probably prevents the development of complication. But then most of the time, we don't get time to start antibiotics because they usually present on the first day itself with encephalopathy. So whether antibiotics are effective or not is difficult to prove. Echo was normal in all the cases. with ECG abnormalities. And TROPI also was negative. Maybe one of the clues to make the diagnosis is initial blood count showing a lymphocytopenia. That's why Yasmin showed those absolute lymphocyte counts showing low values. They have a normal looking total leukocyte count, but then low lymphocyte count, which suggests possible Shigella infection in the correct setting. Potassium levels were normal in these cases.
Did you have any vasoplegic shock or more of myocardic shock?
No, it looked like a cardiogenic shock.
Okay.
It was a constriction. But then almost all the echoes were normal, and TROPI was negative. But these ECG findings were there. This has a lot of similarities with the multisystem inflammatory syndrome, MISC cases that we had, but then not as severe as MISC. And the inflammatory markers are also not as high as we get in MISC. The CRP is maybe around 50 or 60, and ESR is around 30, 40, like not more than that generally.
We had more of vasoplegia like MISC in Shigella, sir.
Yeah, that is correct. Yeah. So I don't know why they have this cardiac involvement here in this. No, IVIG, we are not given IVIG for this reason, for any of the children. But then we have tried IVIG in those cases presenting with toxic encephalopathy, very sick children with severe cerebral edema, thinking that it might help in some way. But then children who really come in that kind of moribund state do not survive. That's our experience.
Which inotrope do you use, sir, initially?
Adrenaline. Almost all of them respond to low dose adrenaline itself. Maybe around 0.1, 0.2 microgram per kilogram.
Steroids?
No, we have not started steroid for any of the children. As such, shock is something not very difficult to treat in these children. That's what we think. But then after, for the first fluid bolus, many of them develop hepatomegaly, tachypnea and all that, fluid intolerance. Ajay, shall we move on to the next case now?
Yes, sir. Yes, sir.
Okay, there's one more question. What is the cause of death? Very likely that this is cerebral edema. That is the reason why they die so fast, I think, in the first 1 or 2 days. And I think the most important thing is to maybe start measures to reduce cerebral edema right from the beginning in children who present with encephalopathy. We start them on 3% saline, initial 5 ml per kg, followed by around 0.5 to 1 ml per kg per hour. I think we'll move on to the next case now. Next case will be presented by Dr. Pooja. It's actually an inborn error of metabolism that she's going to present, a very rare case, but then very interesting also. So let us see. Dr. Pooja?
Yes, sir. So can I start?
Yeah, please start. 1 second. Let me share the screen. Yeah. Can you see the slide, Pooja?
Sorry, sir.
Yes, sir.
Yes, sir. Yes, sir. Yes, sir. So moving on to the next case. Peritoneal dialysis in a fatal metabolic disorder. So next slide. So this was a 7-month-old female child who presented to the PICU. On receiving, she was lethargic, tachypnic, and pink. She had a respiratory rate of 80 with increased work of breathing. Saturation was maintained. She had tachycardia, heart rate was 180 with no shock, and GRBS was 150 and pupils were reactive, but she was lethargic. And in the history, the symptoms were like she had a cough and nasal discharge 3 days back, followed by reduced food intake. And following that, she developed lethargy and breathing difficulty. So in the past history, there were 2 major events. The initial event was on day 2 of life when she was admitted to the NICU with a severe metabolic acidosis, which was corrected with IV sodium bicarbonate given for 2 days. And after this treatment, she was absolutely back to normal and she was discharged on day 15. And though a possibility of a metabolic disorder was considered at this time, because the child completely improved, she was not evaluated that time. The next admission was to our PICU at 4 months of age when she presented with similar complaints, that is lethargy and respiratory distress. And she was found to have a high anion gap metabolic acidosis with a pH of 6.9 and bicarbonate of 2.9. And we ruled out sepsis, shock, and AKI, and we considered the possibility of a metabolic disorder. So on evaluation, she had a normal blood sugar. Her urine ketone body was positive. She had a mildly elevated serum ammonia and a normal lactate and liver enzymes. So because of the severe metabolic acidosis, we started treatment with IV sodium bicarbonate, but she showed no response even after 2 days of IV sodium bicarbonate. And she later developed shock, probably cardiogenic, which was refractory to inotropes because inotropes were not acting in this low pH. And finally, she was so sick that we decided to start peritoneal dialysis as a last resort, thinking that it would help in removing the abnormal metabolites. So PD was started on day 3, and we noted that she was gradually improving. And after 5 days of PD, she completely recovered. There was no distress and sensorium became absolutely normal. So this is a chart from the Hoffman textbook of metabolic disorders. So when a patient presents in a metabolic emergency, these are the differential diagnoses that we consider. The group of disorders are organic acidurias, maple syrup urine disease, urea cycle defects, mitochondriopathies, fatty acid oxidation defects, ketolysis defects, glycogen storage disorders, galactosemia, tyrosinemia, etc. And on the left side, we can see the investigations that we need to do when we get a metabolic emergency. So those are liver enzymes, ammonia, urine ketone body, sugar, blood sugar, serum lactate, and pH. So in this condition, we got a metabolic acidosis with ketonuria and a mild hyperammonemia. So according to this, we were considering possibilities of organic acidurias and ketolysis defect. So for this, we sent a TMS and GCMS, and it was actually inconclusive. It showed only ketosis. There was no metabolite identified in TMS. So we had to send a clinical exam. So next slide. So these are the conditions that can present with acute metabolic acidosis. So it includes all the organic acidurias, fatty acid oxidation defects, and ketolysis defects. So the clinical exam came out to be SCOT deficiency or succinyl coenzyme A 3-oxoacid coenzyme A transferase deficiency. So next slide. So what is SCOT deficiency? It is an extremely rare genetic defect affecting the OXCT1 gene. It is an autosomal recessive condition with an incidence of 1 in 10 lakhs. And worldwide, only around 30 cases have been reported till date. So it's basically a ketolysis defect where there is accumulation of ketone bodies during stress and fasting. That is, whenever the patient has an illness or there is fasting, the fat gets utilized for energy production through beta oxidation. So it produces beta hydroxybutyrate and acetone, which are the ketone bodies. So these ketone bodies are to be lysed to acetyl coenzyme A. So this enzyme SCOT is involved in the breakdown of acetoacetate into acetoacetyl coenzyme A. So when this enzyme is not working, there is accumulation of acetoacetate. So that leads to a severe metabolic acidosis during stress and fasting. The age of onset in this condition is variable, though most of the cases present in the neonatal period itself. And it is characterized by severe ketoacidotic episodes. And the peculiarity is that the child is otherwise asymptomatic in between. There is absolutely no psychomotor retardation. The child will be absolutely neurologically normal. And there are no characteristic metabolites can be identified in the blood except for this acidosis and ketosis. So according to the very few articles which are available on this rare condition, the treatment is to be given with early initiation of IV fluids with a high GIR and IV sodium bicarbonate. And according to our experience, we have found that peritoneal dialysis can also be used as a treatment option when the other options doesn't work, and it can be life-saving. So during the present admission, that is, now the child was 7 months old during the present admission, and the child had a normal development and normal growth with no dysmorphism. Other systems were within normal limits. So this time we had a diagnosis. So the ABG was like pH was 6.9 with a bicarb of 2.9 and anion gap of 32. So according to the treatment options which are available, we started a IV fluid at a high GIR of 6 and IV sodium bicarbonate. But the child did not improve. Like the previous episode, she developed shock and we started inotropes, but there was no improvement. And again, we had to resort to peritoneal dialysis. So PD was started on the same day of admission itself. But she showed a dramatic improvement within 24 hours. Her sensorium was back to normal and there was no distress by 24 hours. So we stopped PD at 48 hours and she was back to her active playful state. And we shifted her back to ward, and at discharge, we have advised to avoid prolonged fasting, and we have advised diet based on cornstarch powder, and we have advised regarding early admission during illness and to the need for IV fluids. And we have given them reagent strips for urine ketone body measurement from home. So concluding, we need to have a high index of suspicion to identify inborn error of metabolism, as they can present to the PICU in a metabolic emergency. The initial investigations that we need to do are blood glucose, ABG, ketone bodies, ammonia, lactate, liver enzymes, and uric acid. And finally, peritoneal dialysis can be a treatment option in certain metabolic disorders, as it can help in the removal of abnormal metabolites. And it sometimes can be life-saving in a fatal metabolic emergency, as in the case discussed. Thank you.
Thank you, Pooja, for that excellent presentation. Now I invite Dr. Sadiq for his comments. Sadiq? Dr. Sadiq? Sadiq, are you there? I think Sadiq is not there. Are you muted? Sadiq? Sadiq has a raised hand.
Sadiq is muted. Ajay?
Ajay?
Sir, unmute.
Thank you, sir. No unmuted. Actually, it was a very, very rare case. It is one inborn errors of metabolism that can present into our emergencies. It is a rare case. It is an autosomal recessive disorder. Actually, it is a ketolytic defect. Ketolysis. Usually, when we are going for a fasting, the fatty acids are used. Then there will be formation of ketone bodies. If there is a defect in ketone body metabolism, it can accumulate the ketone bodies and it will present as a metabolic acidosis. Actually, in this case, the baby presented in 3 times. Actually, in neonatal period, the baby first presented as a metabolic acidosis. That may be a reason for maybe due to any feeding issues. But at that time, it was corrected with IV bicarbonate, and child was completely asymptomatic. That's why they didn't come for another diagnosis. After that, 4 months of age, again this baby came to our hospital with a severe metabolic acidosis. Actually, this was a very sick patient, and tachypnea, mainly acidotic breathing was there. And we saw this ABG as a high anion gap metabolic acidosis. First, we thought it about usually as an organic acidemia. Then we plan to give bicarb and symptomatic support. But in this case, ketone bodies was highly elevated, but there was no hypoglycemia. Then Then we started about giving bicarb and supportive management. After that, this patient was in severe shock because the acidosis was not corrected. So we considered the peritoneal dialysis as a last resort. But this child dramatically improved with the peritoneal dialysis. Then we got this rare diagnosis, SCOT deficiency. Actually, in articles, there is only 20 to 30 reports are available. And in any report, there was no treatment protocol. Peritoneal dialysis was not mentioned in that articles. So we started on peritoneal dialysis as a last resort. But this child dramatically improved. That's why when this child again presented to us, then we early think about the peritoneal dialysis, and we early started on peritoneal dialysis. That's why this baby improved within 24 hours. First event was around 5 days. We put the child on peritoneal dialysis for 5 days. In second episode, it was only just about 24 to 48 hours only. Actually, this shows the importance of peritoneal dialysis in resource-limited settings also. Usual indications, we usually doing peritoneal dialysis in our ICU settings are fluid overload, any renal conditions mainly, fluid overload, uremic encephalopathy, severe hyperkalemia which is not responding to treatment, severe metabolic acidosis, any refractory hyper or hypernatremia. And non-renal causes are in inborn errors of metabolism, usually urea cycle disorders, organic acidemias, and like that. And we can use it as removing toxins also. So we used a bicarb-based solution for this baby, and he was responded very well. And actually, for this disease, it's a ketolysis, ketolytic defect. These ketone bodies are not metabolized properly. In this, they are saying prognosis about the mortality is maximum in neonatal and infant period. After, when the child grows, especially after 10 years of age, the severity decreases and frequency of metabolic acidosis and this stress are decreasing. Then prognosis are good. In this baby, completely there is no developmental delay, no failure to thrive. This baby was completely normal at the time of discharge, and we counseled the mother about the routine checking of urine ketone body and avoidance of stress, avoidance of fasting especially. If there is any medical emergency, please go to the nearby hospital. And one important modality of treatment is IGAR. In second episode, we started IGAR early. That's why the child responded in 24 to 48 hours, comparing to first episode. This is about this disease and the importance of peritoneal dialysis.
Thank you, Sadik. Extremely rare disease, but then very satisfying results once you start the appropriate treatment.
That's something. Any questions?
Are there any questions? Sadik, can you check if there are any questions in the chat box? You can see that here.
Lactic acid and pyruvic acid was normal for this child. Lactate and pyruvate was normal.
Okay. Okay, if there are no more questions, I think we'll move on to the next case. Next case will be presented by Dr. Rose, who is our postgraduate student. Rose?
Sir, that unmute. There is need for unmute.
Sir, unmute ആണ് Rose.
Okay.
Just unmute ചെയ്യാൻ പറഞ്ഞു.
Rose unmute ചെയ്യും.
മേരി ആണോ? അല്ല, റോസ് അല്ലേ സർ?
റോസ്. റോസ്. റോസ് റോസ് ഉണ്ടല്ലോ. co-host.
എല്ലാവർക്കും അൺമ്യൂട്ട് ചെയ്യാം.
ഇല്ല, റോസ് മ്യൂട്ടഡ് ആണ്. റോസ് റോസ് പ്ലീസ് അൺമ്യൂട്ട്. അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റില്ലേ? അജയ്ക്ക് പറ്റുമോ?
സാറേ എല്ലാവർക്കും അൺമ്യൂട്ട് ചെയ്യാം.
ഇൻഡിവിജ്വലായിട്ട് ചെയ്യാൻ പറ്റും അല്ലേ? എല്ലാവരും മ്യൂട്ടഡ് ആണല്ലോ ഇതിലിപ്പം.
റോസ് മെസ്സേജ് ട്രൈയിങ് ടു അൺമ്യൂട്ട്.
ട്രൈയിങ് ടു അൺമ്യൂട്ട്.
അജയ് സാർ ഒന്ന് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും നോക്കി. നേരത്തെ എനിക്കും അതാ പ്രശ്നം പറ്റിയിരുന്നത്.
നേരത്തെ സാദിക്ക് ഔട്ട് ആയി പോയോണ്ട് കോഹോസ്റ്റ് പോയതാ. റോസ് കോഹോസ്റ്റ് ആണ്.
അജയ് നോക്കി നോക്കുക ചെയ്യാം. അതില് അൺമ്യൂട്ട് ആവാൻ പറ്റുന്നില്ലാന്നോ?
കാണുന്നുണ്ട് ഇവിടെ.
ഞാൻ ആക്കുന്നുണ്ട്, ആവുന്നില്ല.
ആരെ ആക്കാൻ പറ്റുന്നില്ല? വേറെ ഏതെങ്കിലും ഒന്ന് ട്രൈ ചെയ്ത് നോക്കും.
I can unmute. It's possible. Maybe some problem with Rose.
ഇൻഡിവിജ്വലായിട്ട് ചെയ്യാൻ പറ്റുന്നുണ്ട് അല്ലേ?
എല്ലാവർക്കും പറ്റുന്നുണ്ട് സാർ. ഓപ്ഷൻ വെച്ചേക്കാൻ.
റോസ് ഒന്നുകൂടെ ഒന്ന് ലീവ് ചെയ്തിട്ട് പിന്നെ ജോയിൻ ചെയ്ത് പറ്റുമോ?
മതി സാർ, ട്രൈ ചെയ്ത് നോക്കാം.
റോസ് ലീവ് ചെയ്തിട്ട് ഒന്നുകൂടെ ജോയിൻ ചെയ്യും.
ഹലോ.
അതെ വന്നു.
ഹലോ.
കേൾക്കാം. റോസ്.
Okay, sir. Slides.
One second. കാണോ slide?
Hello. കാണാം sir.
Okay.
Presenting an unusual presentation of snake bite with altered sensorium. Next slide, sir. A 12-year-old girl referred from Government Hospital Mananthavadi with a history of snake bite over the left foot while walking in the paddy field in the evening. Child had bleeding from the bite area and irritability was also noticed. Whole blood clotting was prolonged and 10 vials of ASV were given within 1 hour of the snake bite. And child was referred to our center for further care. Next slide, sir. On admission in PICU, the child had active bleeding from oral cavity and also from IV cannulation site. Vitals were stable, but the child was irritable. No features of any respiratory paralysis or other neurological deficits. Whole blood clotting time, PT-APTT was prolonged and repeat 10 vials of ASV were given. An emergency CT was done and intracranial bleed was ruled out and the repeat clotting parameters were normal. Next slide, sir. No features of acute kidney injury during the hospital stay. No evidence of capillary leak syndrome except for mild hypoalbuminemia initially. No anaphylaxis to ASV and edema over the limb reduced gradually. Necrotic changes developed over the bite site. Doppler done of the left lower limb was normal and child was on injection crystalline penicillin and injection metronidazole, but the irritability was persisting. Next slide, sir. These are the images of the child of the bite area. We can see that necrotic areas and the huge lesions there. Next slide, sir. And after 3 days of hospitalization, child had worsening of sensorium and abusive talk. No electrolyte imbalance were there. No other features of any raised intracranial hypertension. Now the possibilities considered at this point were intracerebral bleed, ischemic infarction of arterial territories, and it could be ASV-induced immune reaction. And an emergency MRI brain was done. These were the images. Next slide, sir. And we can see in the T2 flare, there is a signal and edematous changes over the cortical and subcortical areas, and also over the basal ganglia region. Next slide, sir. And these changes are suggestive. It could be suggestive of toxic encephalopathy as well as ASV-induced immune reaction. Next slide, sir. And the child was started on risperidone and clonazepam, and there was dramatic improvement in sensorium. And we consulted with the child psychiatrist in our hospital, and the risperidone was continued. And pediatric surgery consultation was done for the necrotic regions, and in IND was done. An asymmetric leukoencephalopathy changes after viper bite is rare, and data in this regard is sparse.
Okay. Thank you, Rose. Now I request Dr. Fiji to make a few comments regarding the case.
Thank you, sir. Thank you, Shrija ma'am and others in the group. So here we have a rare presentation, rare manifestation of snake bite in a 12-year-old girl, tribal girl. We all know the neurological signs and symptoms of after a snake bite due to the neuromuscular junction abnormality as a neurotoxic envenomation of crate and cobra, and rarely viper can also induce this paralysis symptoms and ptosis. But in viper bites, many a time the neurological abnormalities are due to some bleeding into the brain. So anticoagulant or procoagulant activity of the venom induces changes in even ischemic infarcts or bleed into the brain, resulting in neurological abnormality. Or it can be direct neurotoxicity on the brain, or if the child had severe shock or respiratory paralysis, cerebral hypoxia can lead to hypoxic ischemic encephalopathy later, or it may be due to hypotensive shock related. These are the common reasons for neurologic symptoms even in a non-neurotoxic snake bite. Next. So in a neurotoxic snake bite, as all of us know, the common manifestations are ptosis, ophthalmoplegia, limb weakness, respiratory failure, palatal weakness. There will be some slurred speech, difficulty in swallowing, and neck floppiness. This all of us know. But the less common manifestations that we are not always aware or remember are delayed neuropathy. This delayed neuropathy means at presentation, there are no neurological symptoms, only hemotoxic symptoms are there. But after 2-3 days, some neurological manifestation appear. Why that occur? So some reports are there. This is due to direct neurotoxicity or maybe a reaction to the ASV that we give. This antivenom can have two types of reactions. One is early reaction. Most of us have faced it in our PICU experiences. This occurs within 10 minutes to 1 hour usually. That is urticaria to begin with, or sometimes severe anaphylactic shock. This is the main nightmare of anyone giving ASV. Next is late reactions, not so common as acute reactions. This is due to immune complex disease, that is the serum sickness. This occurs usually after 5 days to 24 days after the ASV administration. Here, serum sickness can have fever, rash, arthritis, lymphadenopathy, like that. Along with that, there can be peripheral nervous system manifestations or central nervous system manifestations. These are also associated with serum sickness. Another important but less common manifestation is myocardia, generalized myocardia that I was not much aware of that. A syndrome of continuous and spontaneous muscular activity resembling a fasciculation occurring after snake bite in the victims. Following the treatment, even after giving ASV, some patients develop generalized myocardia. I have not seen yet, but it is in the reports. In Sri Lanka, where most of the snakebite studies have been done, they have published that altered level of consciousness seen in 71% of snakebite victims autonomic disturbance in 66%, andrograde memory loss in 40%, and in delayed neuropathy in 22% in snake bite as a whole. May be related to the complications after snake bite. So what happens to brain in snake bite? Unlike in neurotoxic bite, even with hemotoxic bite, ischemic strokes can occur, and it is in multiple areas, multiple arterial territories, because of the endothelial damage by the toxin. So there is direct endothelial damage by the venom that induces thrombus. There can be an increased tendency because of hypotensive shock. Hemorrhagic stroke can occur as multiple lobar hemorrhages with or without ventricular extension. The reason we all know, it is due to consumption coagulopathy, or due to mainly due to consumption coagulopathy. There can be subarachnoid and subdural hemorrhages, cerebellar hemorrhage, epidural hematoma. All these are due to DIC. There are reports of blindness following snake bite. That is due to optic neuritis. Why they develop optic neuritis? This may be due to the feeding vessels affected. Feeding vessels of the optic nerve, blood vessels are affected. There is vasculitis, ischemia, or even direct injury to the optic nerve. Delayed cerebellar ataxia and disseminated encephalomyelitis are the two manifestations that are thought to be due to immune reaction to ASV. So children given ASV may develop cerebellar ataxia, and some reports are there with ADAM. But if you see, as in this case, this child developed altered sensorium soon after bite, even before the ASV was given. Child was irritable. They had to restrain the child. This was a well-built child. I have seen this child in the duty days in the PICU. They had to restrain the child. At the referral center itself, the doctor had called Jason sir that this child is having some altered sensorium and agitation. This altered sensorium occurring within hours of bite is probably related to the direct endothelial injury caused by the venom itself. And the diffuse cerebral disturbances by toxic leukoencephalopathy. So this is the new entity that we will discuss, toxic leukoencephalopathy. What is toxic leukoencephalopathy? This is rarely described, mainly MRI finding with some peculiar clinical symptoms. What happens here is cortex, the subcortical white matter and the deep gray matter are affected. Mainly it is a damage to the myelin. It is seen with the cranial irradiation, intrathecal methotrexate, some drug abuse like heroin, cocaine abuse. So in such patients or victims, they suddenly present with inattention, forgetfulness, changes in personality. It can be very mild, but it may be like a psychiatric illness or even for severe neurological damage, coma, and death can occur. So in that, the MRI picture is specific findings are there. It suggests toxic leukoencephalopathy. In Western countries, it is mainly reported in drug abusers. This involves the white matter tracts devoted to higher cerebral functions like inattention, forgetfulness, changes in personality, dementia, coma, and death. So this child also have very aggressive behavior, abusive talk and all, which responded rapidly to risperidone and supportive measures. This is very rarely reported in snake bite. After searching literature, I have found only one case report that's in BMJ. This is from India only. Dr. Chowdhury et al. Has presented snake bite induced leukoencephalopathy. This is regarding a 30-year-old female who had altered sensorium, and the MRI was suggestive of leukoencephalopathy. Next. So with this case, what we would like to point out is that snake venoms are complex mixtures of different toxins. We have not yet studied the effects of it. Each neurotoxin has diverse neurotoxic effects. And we always think that there are typical manifestations for different snakes. Like crate has pure neurological, cobra can have neurological, and viper has hemotoxic mainly and sometimes neurological. This may not be always correct. There is considerable geographic interspecies, intraspecies, as well as ontogenetic variations in neurotoxicity with the different snakes. So it varies with the locations also. In some locality, some peculiar manifestations can be seen with the same species of snakes. Like in Wayanad, the viper may be having a different manifestations compared to those in Trivandrum. Accurate identification of envenoming snakes and uniform case definitions are needed to improve the comparability of different reports of neurotoxic envenoming. Most of the time what happens is that these subtle neurological manifestations like altered sensorium or forgetfulness are not at all identified because the patient will be having other serious manifestations. Patient may not be able to talk at all due to paralysis. So these psychiatric manifestations or the higher function abnormalities are often underreported. There are other reasons for these manifestations also, like fear, post-traumatic stress disorder, or hypoxia-induced changes, ICU syndromes. All these can contribute to these changes. There are many interesting acute and delayed neurotoxic manifestations other than this weakness that we all know, and these reveal valuable information. We can understand many pathology of many other neurological disease by evaluating these symptom complexes. So as a conclusion remark, I will say asymmetric leukoencephalopathy after viper bite is a very rare phenomenon and only one case report we have till now. This may be the second one. Jayakshna sir can publish this. Thank you.
Thank you, Dr. Fiji. In fact, Dr. Fiji is the right person to talk about a subject on a topic like this. She has got extensive experience in managing snake bites and all the complications. Thank you, Fiji, for that wonderful presentation. Thank you very much. I think that's the last case. If there are questions in the chat box, I think we can take those. There are no questions now. I think if there are no questions, can we conclude, Dr. Deepu?
Yes, sir. If anybody having any questions, can ask directly also.
Please unmute and ask if anybody feels like asking or discussing anything.
Okay, sir. If there is no more questions, we will wind up the session, sir.
Okay.
Thank you, sir, for the excellent presentation of this case in Asperger, 4 different cases. And we had a wonderful panels with wonderful presentation from PGs. So I would like to thank Jayakshna sir for arranging this session. One question from Chaspo, sir. MRI finding in this case?
MRI was showing signal and changes in the T2 flare in the cortical, subcortical, and also in the basal ganglia.
Okay, then coming to my formal duty, I would like to thank Jayakshna sir for arranging this session. This was an excellent session. Thank you, sir. I would also like to thank the other faculty members, Dr. Shamim, Dr. Sadiq, and Dr. Fiji, for their excellent presentation and analysis of the case scenarios. And I would also like to thank the postgraduates who has done their presentation. And I also like to thank IAP Calicut and Dr. Ajay for organizing this session, the Zoom platform. Thank you all. And I would like to thank all the delegates who has attended this session. Thank you one and all. We will wind up this session.
Thank you, sir.
Thank you very much.
Excellent cases. Thank you, sir.
Thank you.
Thank you, Ajay.